All right, good afternoon, guys. I'm Dr. Baker. I'm one of the fourth-year residents, and this is my grand rounds. Today we're going to talk about benign breast disease. You don't hear me? Is Monroe on? They're not there. They'll let me know. So benign breast disease is one of the most common complaints that a busy gynecologist will see. So the ability to accurately and properly diagnose and differentiate between benign and malignant breast disease is very important. So it's very important for us to be able to identify, like I said, the difference between benign and malignant disease, to identify benign breast disease and patient histories that may predispose to an increased risk of breast cancer, to evaluate and treat the symptoms, and to potentially prevent breast cancer based on identification of high-risk lesions. So this is an overview of my talk today. We're going to review the epidemiology of breast cancer. We're going to look at some of the risk factors for breast cancer. We're going to look at some of the expert opinions for screening for breast cancer. And then we're going to go over the anatomy and pathology of some of the benign breast disease, as well as we're going to review some of the common complaints, most common complaints seen for breast disease, which is going to include breast mass, nipple discharge, and breast pain. And at the end, we'll go over a couple of cases to incorporate everything. So incidence. This is from the Cancer Journal of Clinicians, Cancer Statistics for 2014. And so, as you can see up top, it's the estimated new cases. And so when you look over to the right, you see female. So for breast cancer, they estimate that in the year 2014, there'll be approximately 222,000 new cases of breast disease, which is going to be 29% of the total new cases of cancer diagnosed in females. When you look at estimated cancer deaths, breast disease comes second only to lung and bronchus cancer. And that's going to be, 40,000 or 15% of the cancer deaths. So when you look closer at the age of the patient, this is from the American Cancer Society figures from 2009 to 2010. And this is the age-specific probabilities of developing invasive female breast cancer. And so you can see on the left, they've got your current age and then the probability of developing breast cancer in the next 10 years or 1 in whatever. So for instance, every female has a lifetime risk of 12% of breast cancer or 1 in 8. I have boxed the 40-year-olds. This is the age that brought up a lot of questioning and the new changes in recommendation of screening. And so as you can see here, there's a steady increase of the probability of developing breast cancer. There's no abrupt change between 40 and 50. So let's go over some of the risk factors. So some risk factors are unalterable and some you can alter. So a woman's age. Breast cancer is clearly linked to age and a woman's not going to be able to alter that. All females are at increased risk of breast cancer as compared to men. You can't change your family, personal history, genetics, race, treatment with DES, or radiation to the chest or thoracic area, or your reproductive history. When you look at race, white women are at increased risk of diagnosis of breast cancer, and African American females are at increased risk of cancer deaths. So some of the factors that can be controlled. Exercise and breastfeeding are both protective and decrease the risk of breast cancer. Alcohol, 2 to 5 glasses a day, is about a 1.4 increased relative risk of breast cancer. Hormone replacement therapy, not having children, and obesity. And obesity especially in the postmenopausal age. So here we can look at the risk factors again, and we're going to kind of focus in on the reproductive or the estrogen-progesterone exposure risk factors. And these are going to include early age of menarche, late age of menopause, nulliparous, late onset of first pregnancy after 35, and a long-term use of menopausal hormone therapy all tend to increase the risk of breast cancer. Factors that interrupt the estrogen-progesterone exposure, like multiparity, breastfeeding, and premature menopause are all protective. And so a study done by Kelsey and al. Looked at the reproductive risk factors, and this was a large meta-analysis study. And what they did was, in part of it, they focused on the exception of the later onset of having your first child. And so what they found was that the indifferentiation of breast tissue into mature breast cells prepared for lactation with the first pregnancy is associated with permanent changes in the biologic properties of the glandular epithelium. And these changes cause the cells to spend more time in the repair phase, or the G1 phase of the cell cycle. The later the age of the pregnancy, of the first pregnancy, the more likely that the DNA errors have occurred that will be propagated through the proliferation of the cells during pregnancy. Although early menarche and late onset of pregnancy are both increased risk for breast cancer, it is what's more relevant is the number from menarche to the first pregnancy. So risk assessment tools. There's a growing interest in trying to stratify women into groups of different levels of risk for breast cancer. Several breast cancer risk production tools have been developed that combine the major risk factors. And the purpose of this is to better stratify women into risk categories that can be used to tailor the screening decisions and strategies for clinical management of the individual patient. So the most widely available tool that I'm sure we've all heard about is the Gale model. And this was done by Dr. Mitchell Gale at the National Cancer Institute. And this tool is based upon data from developing breast cancer. The data came from the Breast Cancer Detection Demonstration Project and the CARE trial. And what it does is it gives the risk of developing breast cancer within the next 5 years until the patient turns 90. And this is based on a couple of things. So they look at the patient's current, and then you just go to the web page down here and you plug all this in. So you plug in the current age, age of menarche, age of first birth, number of first-degree relatives with breast cancer, number of previous breast biopsies, whether or not these breast biopsies showed any atypical hyperplasia, and then I didn't add on here race. So, I'm going the wrong way, sorry. So it sounds like it has a lot of good things that it adds in to help predict the risk of breast cancer. So how good is this test? This test is periodically updated with results of new studies to help modify the relative risk of cancer. When you look at risk assessment tools, there's a couple of tests that look at how good the test is. The first is going to be calibration. And calibration measures the tool at a population level in a large group. It determines how accurately a model predicts the observed rate of cancer and is measured by comparing the number of women in the group predicted to have breast cancer to the number who are actually diagnosed with cancer. A good calibration, for example, is going to be 1. The Gale model in multiple studies has a population level calibration at 0.94 to 1.03, which is good. So next you can look at concordance, or Cysts statistic. And this is the proportion of randomly selected pairs of women with and without breast cancer diagnosis, in which women developing breast cancer has a higher calculated risk than women without the disease. And the range for C statistic or calibration is going to be 0.5 to 1. And it is a probability of predicting the outcome is better than chance. And so 0.5 is going to be just relative chance. A good C statistic is going to be anywhere above 7, and a strong is going to be over 0.8. And so where the Gale model fits into this on multiple studies, their C statistic is 0.58 to 0.63. So therefore, the Gale model does not discriminate well in the individual level. And this is different than what we just talked about with the calibration, which was at a population as whole. And last, discrimination, and we're familiar with this. This assesses the performance at the individual level and involves determining how well the model stratifies women into those who do and do not develop breast cancer. And so this is talking about your sensitivity. So the sensitivity of the Gale model is 28 to 44% in multiple studies. Your specificity is going to be anywhere between 66 to 88%. And the positive predictive value is found to be around 2.3%. So again, this study isn't good at the individual level. So that's why we don't use it all the time. So breast cancer screening. So the goal of screening is to reduce, the goal of cancer is to reduce mortality, to detect the cancer early when treatment is more effective and has fewer morbidities. Recommendations for breast cancer screening rely on a combination of several factors, looking at the risk of the condition, the benefits and harm of the screening, and the cost. However, it is very important for us to remember that 75% of women diagnosed with breast cancer do not have any risk for breast cancer. So mammogram. Mammogram is the best screening tool available. Cancer detection rate is 5 per 1,000 screening examinations. Detection rate and is 11-fold higher at 55 per 1,000 when imaging is performed for a specific finding. It has good sensitivity, approximately 90% in fatty breast, 80 to 90% sensitivity on the average breast. It's inexpensive and widely available. And so when you look at mammogram and where they find the cancers, these are 2 studies that kind of talk about the benefits of mammograms. Guth and al. Looked at the tumor size and detection of breast cancer, and this was done in cancer detection in 2008. And then the Cancer for Female Breast U.S. SEER program from 1988 to 2001, looking at the tumor characteristics. So cancers were found in a median size on just a routine screening mammogram from 1 to 1.5. Approximately 10% of invasive cancers at 1 centimeter in size or smaller have spread to the lymph nodes at the time of detection, versus approximately 35% if the cancer is 2 centimeters in size, or 60% of those that are 4 centimeters in size. So a 2 centimeter smaller invasive cancer, which has not yet spread to the lymph nodes, is stage 1, which a 5-year disease-free relative survival rate of over 98%, compared to 86% for stage 2 disease. So let's look at the breast cancer screening recommendations, and this is in the handout, and I think it's the first page. So here you can see the different expert groups. You've got ACOG, American Cancer Society, National Comprehensive Cancer Network, National Cancer Institute, and U.S. Preventative Services Task Force. And so, as you can see here, everyone recommends screening at age 40 except for the U.S. Preventative Services Task Force. And we're going to kind of go over a lot of the studies they used of where they came up with their recommendations. They actually came out and recommended against screening 40 to 50-year-olds in their statement in 2009. There's been a little differences among the self-breast instruction versus breast self-awareness, and this is kind of just a play with words. And so we're kind of moving a little bit away from telling the patient to do a specific type of breast exam and moving more towards just breast awareness, for her to know what her breasts look like, the nipples look like, skin, any retraction, and the density and texture of her breast. So age. So when you look at the benefits versus harm, benefits, absolute decrease in breast cancer mortality, and the harms, false positive screening tests and overdiagnosis, are greatly influenced and vary by age. So this is a study done by Nelson and al., Screening for Breast Cancer, an update in the U.S. Preventative Services Task Force, and this is from 2009. So this is a pooled relative risk for breast cancer mortality from mammography screening trials compared with control women, and this is looking at women aged 39 to 49. So this is a meta-analysis. On the left side you can see all the 8 different studies they looked at, which gave them a total of approximately 150 in the screening and about 200,000 in the control group. And they found a 15% reduction in breast cancer mortality in women ages 39 to 48, with a relative risk of 0.85 with a 95% confidence interval of 0.75 to 0.96. So when they took that study, they took this 0.85 that we just looked at and compared it to the different age groups. And what they also added to this was the number needed to invite. So this is very similar to number needed to treat. So the number needed to invite to detect one breast cancer, to prevent one breast cancer death, excuse me. And so as you can see, the 39 to 49-year-olds and the 50 to 59-year-olds had the same, almost the same relative risk for breast cancer mortality. But what the difference is is the number needed to invite. So the 39 to 49-year-olds, they needed to invite 1,900 versus approximately 1,300 in the 50-year-old group. And this has a lot to do with the prevalence of breast cancer. So there's more breast cancer in the 50-year-olds, which is why they had to invite more of the younger patients, as well as more false positive results in the younger patients due to dense breasts. And so here they look at, this is just kind of going on when they look at the number of procedures to diagnose one case of invasive breast cancer. And they looked at the 40 to 49-year-olds and the 50 to 59-year-olds. So what they're looking at is, rather than benefiting from screening, women without cancer undergo mammogram and additional imaging and biopsies that may incur harm. Here you can see that the women in their 40s underwent 556 mammograms, 47 additional imaging images, and 5 additional breast biopsies to diagnose one case of invasive breast cancer, versus the 59-year-olds at 294 mammograms, 22 additional imaging studies, and 3 biopsies. So this is by Hubbard and al. And again, this is just going along more with the data from where the U.S. Task Force is coming with. And this is the cumulative probability of a false positive recall or biopsy recommendations after 10 years of screening mammography. This is a prospective cohort. They looked at 7 mammography registries in the National Cancer Institute, and they found about 170,000 women who received the first screening mammogram between the ages of 40 and 59 between 1994 and 2006. And they found 4,400 women with the incidence of invasive breast cancer diagnosed between 1996 and 2006. And so what they're measuring is the false positive recalls and biopsies. So what they found when they looked at women aged, here you can see they're comparing the women aged at 40 versus 50. And if they were screened annually or biannually, between the 40 and 50-year-olds. And so you can see that there was about a 61% chance of having a false positive, 61% chance of having a false positive in the 40-year-olds and in the 50-year-olds. However, when you look at screening every 2 years, it goes from 61 to about 41%. And so what they found was that the screening decreased your risk of false positive scans, but they did note in this study that they did note the study that the probability of being diagnosed with a later stage of breast cancer was increased with the patients who did have the every 2 years of screening. So this is a study done, this is one of the Swedish studies, so this is coming from the other side of pushing more towards screening every 2 years, and this is a Swedish study looking at breast cancer screening with mammography in women aged 40 to 49. And what this is looking at is the expected percent of women with breast cancer whose lives will be saved by mammographic screening compared with not screening for different age groups and screening intervals. And so here you can see the different age groups and your screening intervals. And what you'll notice is this huge difference between the 1 year and 2nd year and 3rd year for this 40 to 49 group versus the 50 to 59-year-olds and 60 to 69-year-olds. There's not as much of a dramatic decrease between the screening intervals. So what they found is that women with, who are diagnosed with breast cancer in this younger age have more of the aggressive cancers. And so it benefits them from having a screening every year. So here is just the U.S. Task Force, and this is their overall recommendations. They say that with their screening frequency, they predicted 81% of the benefits of screening, mortality reduction, could be maintained by screening every other year. This is less resource intensive and is predicted to reduce the false positive rates by approximately 50%. So what about the women who are recommended against screening in their 40s? This is a study done by Krystle N, and they looked at the U.S. census data in 2008. And there were approximately 22 million women aged 40 to 49 this year. Based on the Surveillance Epidemiology and End Results Program, or the SEER data, breast cancer deaths expected over 10 years were estimated at 204 per 100,000 women aged 40 to 49. This 10-year death rate leads to an estimate of approximately 45,000 deaths of U.S. women aged 40 to 49 over a 10-year period. And so when you go back and look at the 0.85 relative risk, or 15% reduction of breast cancer, it estimates that, approximately 38,000 deaths would occur in a screened population over 10 years. And so that's approximately 6,800 fewer deaths than expected with the 10-year death rate. So your anatomy and physiology. Excuse me. The breasts are a large sebaceous gland. The mature breast weighs approximately 200 to 300 grams during the menstruating years. And it consists of approximately 20% of glandular tissue and 80% of fatty connective tissue. And after menopause, the glandular tissue is going to regress and is going to be replaced by fatty tissue. The periphery of the breast is predominantly fatty tissue, and as you can see right here, the glandular tissue is more in the central area. You do have a lateral projection of the glandular tissue that extends to the upper outer portion of the breast, which is going to be called the axillary tail of Spence, as you can see here. So each breast is composed of 12 to 20 triangular shaped lobes, as you can see here. Here's a lobe. And each lobe contains an independent ductal system. The lobes are composed of lobules, 10 to 100 per lobe. Within the lobules, there are secretory cells that drain into the alveoli or the acini, and these alveoli drain into terminal ducts, which coalesce into larger collecting ducts, finally joining with other ducts from the lobules to end in a small series of lactiferous sinuses ending in the excretory ducts at the nipple. You do have fibrosepta, which you can see right here, which is the Cooper's ligament. And this extends from the skin all the way to the pectoralis major, and they are believed to offer support for the breast. Invasion of these ligaments by malignant cells produces skin retraction, which is a sign of advanced breast cancer. So what happens to the breast as we age? During reproductive years, these terminal, the terminal ducts near the acini and themselves are most sensitive to the ovarian hormones, your estrogen and progesterone, as well as prolactin. Most forms of benign and malignant disease occur in this area. The breast epithelial cells proliferate during the luteal phase of the menstrual cycle when exposed to estrogen and progesterone, and these levels are increased and undergo a programmed cell death at the end of the luteal phase when the hormones decrease. This is recognized as breast fullness as well as tenderness the week preceding menses, and is associated with an increase of water content in the extracellular matrix, and an average increase of 25 to 30 cc's in the premenstrual breast. So here you can see the tissue changes secondary to hormone levels. And here you can see the normal non-pregnant breast tissue. Let's see my error. You've got your center is the breast lobule, in which the system of the terminal ducts and the ductules are embedded in the loose intralobular fibrocollagenous stroma, which is right here. There's a narrow surrounding zone of dense extralobular fibrocollagenous support tissue. On the outside of that, you can see your adipose tissue out here. Here you can see this is glandular hyperplasia in the pregnant patient. These are those glands proliferating. And here you can see the postmenopausal atrophy with the replacement of the adipose tissue. Here you can see this is just your milk line, and you can have supernumerary nipples or polythelia here, as well as extra breast tissue, which is normally here in the axilla. So pathology. When you look at the pathology, benign breast disorders are split into 3 groups. Non-proliferative, which does not have a relative risk of increase of breast cancer. Proliferative, without atypia, and that's got about a 1.3 to 1.9 increased risk of breast cancer. You can see the types that are associated with this. And atypical hyperplasia, which is a 4 to 5 times relative risk of increase of future breast cancer. And so when we look at breast masses, you've got fibrocystic breast disease. And so this is the most common of all breast disease. It's most common between women of age 35 to 55 years old. 50% of the women with fibrocystic changes have clinical symptoms. And it's believed to be associated with the imbalance of progesterone and estrogen. So here you can see your fibrocystic changes, and we're going to look at that a little closer. And so this is thought to be due to the hormonal stimulation, which may result in the dilated fluid-filled lobular acini, interpreted as microcysts, on histologic sections, and is usually accompanied by relative stromal abundance. So here you can see both of those. In many cases, pain and discomfort coincide with the premenstrual phase of the cycle, in which the cysts tend to enlarge. And you can see fluctuations in the cyst and actually rapid appearance as well as recurrence of these cysts. And here's just a little more. This is just benign breast cysts in themselves, so apart from fibrocystic breast disease. And so it's mostly from the apical metaplasia of the lobular acini. So again, talking about this terminal duct unit right here in the end part. So the incidence of breast cysts peak between the ages of 40 to 50 years old. And there's a lifetime incidence of 7%. Davies and al. did a study in 1964 looking at the prevalence of cysts in autopsy studies, and they found that microcysts were present in about 58% of the autopsies they looked at, and 21% of the cysts were over 1 centimeter. So this is from Williams, and it's looking at the different types of breast cysts. And so you can group them into 3 different groups. You've got simple breast cysts, which you can see up here in the top left. And these are going to be sonolucent. They have very smooth margins and show enhanced thorough transmission. These do not require any special management or monitoring, may be aspirated if painful. After aspiration, there is about a 30% chance of recurrence, and if there is recurrence, you're going to want to excise these. Next is a complicated cyst, and so these cysts are kind of a combination of these 3, and they show internal echoes and can be indistinguishable from, it's hard to distinguish them from solid masses. And so these should be aspirated, and we're going to kind of look at a diagram of the different types of cysts and what to do. And then you have your complex cysts, which you can see here. Complex cysts show septa or intracystic masses on a sonographic imaging. Septations are usually represent papillomas, but medullary carcinoma, papillary carcinoma, and infiltrating ductal carcinoma cannot be differentiated between these complex cysts on imaging alone. And so on physical exam, fibrocystic breast disease, the patients usually will have tenderness on exam, they'll have increased engorgement and more dense breast, increased lumpiness, and occasional spontaneous discharge. On imaging, like we talked about, the mammogram, you'll have a cystic outline. There should be no calcifications or no increase in density in your simple cyst. On ultrasound, you can see a cyst. So what do you do when your imaging shows you a cyst? If you have a simple cyst like we talked about, you can observe or aspirate if the patient is symptomatic. If they have a complex mass, you go straight to excision. The complicated cysts are the ones that are kind of in the in-between between the simple and the complex. You're going to want to aspirate and send for cytology. If there's bloody fluid or the cytology is positive, you're going to want to go straight to excision. And if it's non-bloody and the cytology is negative and it resolves, you're going to want to re-examine this patient between the next 3 and 6 months. If there is reoccurrence after the aspiration, then you're going to want to excise this gland. Excise this cyst. And if there's no recurrence, then go to their routine follow-up. So management of fibrocystic change. This does not require specific treatment. You just treat the symptoms. And so in the end, we're going to kind of go over breast pain, which is the symptoms that these patients present with. So there's a lot of articles that you'll see on fibrocystic change and the risk for breast cancer. And this is a study done by Cabot, a multi-center prospective cohort study of benign breast disease and risk of subsequent breast cancer done in Cancer Causes Control in 2010. And so what they found is that fibrocystic change was not associated with an increased risk of breast cancer unless there is histologic evidence of epithelial proliferative changes with or without atypia. So on their findings, they found that approximately 70% of the cysts were non-proliferative, 30% were proliferative, and 3.6% had atypia. Atypical or lobular hyperplasia had approximately a 5-fold higher risk than women with non-proliferative disease to develop invasive breast cancer. And carcinoma in situ had a 10-fold risk of developing breast cancer. So the second most common breast mass is going to be the fibroadenoma. And these are benign solid tumors containing glandular and fibrous tissue. They're commonly found in women between the ages of 20 and 35 years old. The cause is unknown, however, they're thought to be due to hormonal influence. And it may increase in size during pregnancy with estrogen therapy. So here you can see your fibroadenoma. These usually present as a well-defined 2 to 3 centimeter mobile mass, which arises from the epithelium and the stroma of the terminal duct lobular unit that we were looking at earlier. Ultrasound is useful in distinguishing a simple cyst, which you can see here, from the fibroadenoma. On mammogram as well as ultrasound, they typically appear as well-defined, smooth, solid masses with clearly defined margins. A suspected fibroadenoma should be confirmed by FNA or by core biopsy and observed for any increase in size or excised for the patient's preference due to symptoms. Transformation to cancer from a fibroadenoma is very rare, and regression is frequent. Therefore, the management of these patients is conservative. So some patients we talked about earlier, these are 2 to 3 centimeters. You can have giant fibroadenomas that overcome 10 centimeters in size. And they do recommend excising these. And so you can see that here's one of the larger tissue, one of the larger fibroadenomas. Also, there's a juvenile fibroadenoma, and these are found in young women between the ages of 10 to 18, and they vary in sizes between 50 to 20 centimeters in diameter. They're usually painless, solitary, unilateral masses, and they do recommend excision of these. So next, when you're looking at the different types of pathology, you have your hyperplasia. This is your ductal hyperplasia. And here you can see the differences between the slides, between normal epithelial hyperplasia, atypical hyperplasia, invasive, and then go into invasive cancer. So proliferation of, you have proliferation of your luminal epithelial cells, which results in terminal ducts or acini with several layers of cells, which is referred to as ductal or lobular hyperplasia. And you can see that here and this one right here. As the process progresses to the atypical hyperplasia, the terminal ducts of the acini become packed with cells, which begin to show nuclear atypia in these. And this condition is referred to as the atypical ductal hyperplasia or atypical lobular hyperplasia. And as more and more of the terminal ducts and acini become involved, this condition is recognized as ductal carcinoma in situ or lobular carcinoma in situ. So next we're going to look at some of the common complaints and presentations. A breast mass is going to be the #1 complaint of breast complaints. Approximately 90% or more of the breast masses palpated in women in the ages of 20 to 50s are benign. However, you must exclude breast cancer at any age. A dominant mass is characterized by the persistent through the menstrual cycle. So here you can see, this is from Perlman et al., benign breast disease printed in Obstetrics and Gynecology in 2010, and this is in your handout of a flow chart which is also suggested in Harris of benign breast disease, when you have a patient that presents to you with a benign breast, with a breast mass. So you want to perform a history and a clinical breast exam. And so when you look at we're going to kind of go back to that in just a second. What you want to talk about is the breast lump characteristics. Were there changes in size over time? Changes related to the menstrual cycle, duration of the mass, pain or swelling, redness, fever, or discharge from the mass. You also want to talk to them about their diet and medications. Next, you want to talk about family history, and we've already talked about this. And her medical and surgical history. Has she had any operations or trauma to the breast? Then you want to look at the patient's personal history. So these are going to be your risk factors for breast cancer that we talked about earlier. Age at first childbearing, age at menarche, age at menopause, current age, current lactation status, history of breastfeeding, and number of children. Social history, including any radiation to the chest or smoking. On physical exam, things that are going to make you think more of a benign mass, they're going to cause no skin change. It's going to be smooth, soft to firm. They're mobile and have well-defined margins. Masses that are going to make you a little more worried, thinking about malignant masses, are going to be masses that are hard, immobile, fixed to the surrounding skin, nipple retraction, any skin changes, and poorly defined irregular margins. So after you do your history and clinical breast exam, then you kind of are brought to this. So if the clinical exam suggests no mass, then you repeat the clinical exam in 2 to 3 months. If the clinical exam suggests a probable benign mass or asymmetry, you're going to want to do some imaging. So if the patient is less than 30 years, you want to do an ultrasound. And if they're over 30 years, you want to order a mammogram with or without ultrasound. And so on their imaging, these are the BI-RADS, and we're all familiar with this. So if it's BI-RADS 1 or negative, you want to repeat their exam and consider a biopsy if clinically suspicious at the next exam. On BI-RADS 2, this is found to be benign. You'll do routine follow-up for these if consistent with the exam. If the exam is suspicious, same for this, you might do an excisional procedure. On BI-RADS 3, which is probably benign, you want to repeat your imaging in 6 months and a biopsy if clinically indicated. And if it's BI-RADS 4 or 5, which is suspicious for breast cancer, you're going to biopsy. This is going to be image guiding, like core needle biopsy, which is preferred. And if your clinical exam suggests a suspicious mass, you're going to want to order a mammogram, and this is going to be your diagnostic mammogram as well as an ultrasound. Send this patient to your breast surgeon, and they're going to do a biopsy. So this is going to be the imaging difference between benign and malignant masses. So in benign on imaging, they're going to be a smooth contour, well circumscribed, encapsulated with possibly a halo sign, and these will not change in much size or shape. The malignant masses grow significantly. They have stellate, or they have these starburst kind of shaped masses that you can see on imaging that extends in all directions, as well as calcifications. So we already talked about some of the breast masses, and we'll just kind of go over a few more. This is the Phylloides tumor. This is a rare fibroepithelial tumor, which is rapidly growing. These are epithelial lined spaces which are surrounded by cellular stromal cells and are monoclonal and neoplastic. They are characterized or classified as benign, intermediate, and malignant. And they're based on degrees of stromal cell atypia, number of mitosis, tumor margin characteristics, and abundance of stromal cells. They are rarely bilateral. It's difficult to distinguish clinically from a fibroadenoma, so you want to do some tissue biopsy. And they can range in size between 1 to 50 centimeters. And your treatment goal for this is a wide local excision with a 1 to 2 centimeter margin. And so this was a study by Chen et al., surgical treatment by phylloides tumors in the breast, a retrospective review of 172 cases in the Surgeonc Journal in 2005. And what they found that of the excisions, 70% of these were benign, 23% were malignant, and 7% were borderline. So when you look at the prognosis of these different type of masses, benign was cured with surgery. The intermediate 5-year survival was 90 to 100%. The 5-year survival for malignant disease is approximately 60 to 80%. Malignant with METs, the overall survival was 30 months. And if it recurs, it will usually happen in the next 2 years after excision. So here you can see this is fat necrosis, and this is rare. This usually presents as a tender, ill-defined mass, and it's secondary to trauma. Often the patients don't remember the trauma they found. It's clinically important if it produces a mass, and if it produces a mass and you need to work this up. These masses are often accompanied by skin or nipple retraction, as you can see here in this picture, and it's indistinguishable from a carcinoma. Therefore, you need to excise these masses. A few more masses, like lactocele, we're familiar with this. This is a milk-filled cyst from over-distension of the lactiferous duct. It presents as a firm, non-tender mass in the breast, as you can see right here. It's commonly in the upper outer quadrants beyond the areola, and diagnostic aspiration is often curative. Ductal ectasia is generally going to be found more in your older women. Dilation, they're going to have dilation of the subareolar ducts. They have a palpable retroareolar mass. They can have discharge, which can be often green, or retraction of nipple, which can be present. And treatment is going to involve excision of the area, and here you can see that. Next, we're going to look at breast inflammation and infections. During pregnancy and not during pregnancy. The ones not during pregnancy do not respond as well to antibiotics, and therefore you might need to do a biopsy on these. And so here you can see this is a breast abscess. These can be present with breast swelling and tenderness as well as fever. On physical exam, it's tender, warm, with a fluctuant mass, and may have purulent discharge. They are characterized either peripheral or subareolar. Your peripheral abscesses are going to be more skin infections like folliculitis or infection of the epidermal inclusion cyst or Montgomery glands. And they are adequately treated with drainage and antibiotics. When you look at your subareolar abscesses, these arise from keratin-plugged milk ducts, which directly are behind the nipple. This usually presents under the areola with fistulous communications between multiple abscesses. Simple drainage has a recurrence of 40%, and this is most likely due to these communications between the abscesses. The most effective treatment, therefore, requires subareolar duct excision and complete removal of the sinus tracts with biopsy of the abscess wall, as breast cancer occasionally presents as an abscess. So here you can see just the congenital breast disease, and we already talked about this with your milk line. You can see your extramammary breast tissue as well as the excessive nipple. And these are most common. The most common site for your accessory nipple is going to be below the breast. The most common site for the accessory breast tissue is going to be in your axilla. These rarely require treatment except for cosmetic reasons. So breast pain. This is very common to the general physician who sees breast disease. About 30 to 47% of breast clinical evaluations. 70 to 80% of women experience breast pain at some time during their lives, and approximately 15% of these have such severe pain that it requires investigation and treatment. It's more common in the premenopausal women than in postmenopausal women, and can be cyclical, non-cyclical, or extramammary pain. So when you look at your cyclical pain, this is going to be most common in women in their 30 to 40 years of age. It accounts for 2/3 of all breast pain symptoms. And this is often described as heaviness, swelling, and tenderness that radiates to the arm and the axilla, usually bilateral, diffuse, and most severe during the late luteal phase of the menstrual cycle, and it resolves with menses. This can be attributed to fibrocystic breast changes, as we talked about earlier. And the etiology is unknown, but it's likely related to the estrogen progesterone changes and the interstitial water content, like we talked about earlier. This requires no specific evaluation and is managed symptomatically with NSAIDs. A variety of other treatments have been proposed, including bromocriptine, vitamin E, primrose oil, but these outcomes have not been proven to be statistically significant, or these treatments have not been proven to be statistically significant. So your non-cyclic pain, instead of the 30 to 40-year-olds, this is going to present in a little older group, the 40 to 50-year-olds. This one is often unilateral, and this pain is usually sharp, burning pain that's localized in the breast and is not related to menses. Occasionally, it's secondary to the presence of a fibroadenoma or a cyst. Menstrual irregularities, emotional stress, trauma, scars, pain at previous biopsy sites or medications have been associated with non-cyclical pain. So here, evaluation and management of breast pain. You've got mastalgia to be treated when it's severe enough to interfere with a woman's lifestyle, or if it occurs more than a few days every month. And so what you want to start off with is a good history and physical and a diagnostic workup. So this is from Williams Gynecology, and it's just what they suggest is your workup of your breast pain. And so if they have the focal pain, you want to do a clinical exam and diagnostic imaging, whether it may be mammogram or ultrasound. It's according to the age of the patient. If your imaging and exam is normal and the pain is mild to moderate, you just reassure the patient. If they have severe pain, you can use the medications that we talked about earlier, and we'll go in a little more in depth on the studies that show which one are beneficial to the patient. If your clinical exam or imaging is abnormal, you need to do a biopsy or whatever the imaging is showing you that you might need to do, like we talked about earlier. If they have diffuse and bilateral pain, you need to look and see if it's cyclic or non-cyclic. For the non-cyclic, you want to start off with a prolactin and an HCG. This can be due to hyperprolactinemia. For these patients, you want to get a brain MRI, possibly treat them with bromocriptine. If the HCG is positive, reassure the patient. And if it's normal, again, if they have mild to moderate symptoms, reassure the patient. If it's severe, you can treat them. So for your cyclical, diffuse, bilateral breast pain, mild to moderate, reassure, and severe, treat. So your treatment goals are to alleviate the pain, reduce or relieve any irregularity, rule out cancer of the breast, and it's important to know that surgery has no role in the management of breast pain. So your diet and lifestyle modifications that we've all heard about are going to be elimination of caffeine and chocolates, reassurance, supportive raw, low-fat, high complex carbohydrate diet, vitamin E supplementation, and evening primrose oil. The low-fat diet was effective in one study done by Boyd et al., published in the Lancet in 1998. And they found that 90% of patients that had a 15% dietary restriction of a low-fat diet experienced resolution of pain after 6 months, compared with only 22% of the patients that had a 36th percentile makeup of fat in their diet. Evening primrose oil has been studied in multiple studies. It contains essential fatty acids which decrease the effect of prostaglandin synthesis, but none of these have found to be statistically significant. Here you can see medications for treatment. You can treat them with NSAIDs, you can treat them with OCPs. If the pain is associated with their breast, with their cycles, you may want to keep them on continuous OCPs. Danazol is the only FDA-approved medication for breast pain. And 75% of patients with non-cyclical breast pain will be symptom-free with Danazol. The issue with this is the side effects. They have weight gain, menstrual irregularity, acne, and hirsutism. Also, you can use bromocriptine, 2.5 milligrams BID for 3 to 6 months, and this is a prolactin antagonist. So last of the presentations is nipple discharge. The majority of cases of nipple discharge are benign. It's the most common cause is lactational, and it can be either spontaneous or expressed. Benign discharge is going to be bilateral, expressed only, milky or green in color, and multiductal. Suspicious discharge is going to be more of the unilateral, uniductal, spontaneous, clear, serous, bloody in color, and this requires further workup. So we put nipple discharge into 3 categories. You have normal lactation, galactorrhea, which is outside of the normal lactation, milky discharge outside of the normal lactation, and non-milky discharge. So normal lactation, bilateral milky nipple discharge which is present during pregnancy and can be present and lactation and can be present up to 1 year after. Galactorrhea is bilateral milky discharge outside of the normal lactation, not caused by intrinsic causes. And so the last is non-milky discharge. And it can either be spontaneous or expressed, unilateral, bilateral, uniductal, multiductal, and the color can be clear, yellow, green, multicolor, or bloody. A suspicious non-milky discharge is going to be the unilateral, spontaneous, bloody, serosanguinous discharge from a single duct. It's normally caused from intraductal papilloma and rarely caused by cancer, but you still have to work it up. So here's your intraductal papilloma. You can see right here. It's a benign growth within the ductal system. It presents as bloody nipple discharge. Excision is the only way to differentiate from carcinoma. On nipple discharge, you have a couple of different causes. You've got non-neoplastic. This is going to be your galactorrhea, your physiologic changes resulting from mechanical manipulation. Paris conditions, periductal mastitis, subareolar abscesses, fibrocystic change, and mammillary ductal ectasia. Your neoplastic causes are going to be your solitary intraductal papilloma, carcinoma papillomatosis, squamous metaplasia, and adenosis. And extramammary causes are related to hormones and drugs. That is beyond the scope of today, but 14% of those are physiologic conditions, 18% are neoplastic processes. Less than 10 are going to be from your hypothalamic pituitary disorders. Under 10 is going to be your systemic diseases. 20% are medications. Medications that can cause some nipple discharge are going to be antidepressants. Some of the antihypertensives like atenolol, Aldomet, Verapamil, antipsychotics, histamine blockers, hormones and herbs, chest wall irritation, and 35% is idiopathic. So this is from Perlman et al., and this is from the article in Obstetrics and Gynecology in 2010, benign breast disease. And so when a patient presents and complains of nipple discharge, you want to perform a history and a clinical exam. If you identify a mass, you're going to go to your mass algorithm that we talked about, patient stratify. If the discharge is spontaneous, unilateral, single duct, and reproducible on exam, you want to order a mammogram and an ultrasound. If it's BI-RADS 1 to 3, you want to order a ductogram and excise the involved duct. If it's BI-RADS 4 to 5, they'll perform a biopsy under the imaging abnormality. If the discharge is bilateral and milky, order a pregnancy test. If HCG is negative, you perform the workup for galactorrhea. Review medications, check a TSH, check prolactin. So if the discharge is expressed only, multi-duct, if the color is yellow, green, gray, or black, you can observe this patient for about a month and avoid nipple stimulation, or order a mammogram if aged 40 or older, and the last mammogram was over a year ago. If symptoms are bothersome to the patient, consider duct excision, and they need a repeat exam in 3 to 4 months for stability. So cases. So you come into the acute clinic and you have 3 patients who present with a breast mass. One is 23, one is 35, and one is 55 years of age. How will you approach the 23-year-old with a 2 by 2 by 2 centimeter firm, mobile, well-circumscribed, non-tendinous mass in the left breast? Imaging of choice for this patient is ultrasound. Ultrasound is beneficial for patients, especially under 30 years of age. The patient is spared radiation exposure. It differentiates between solid and cystic masses. It also provides guidance for any kind of interventional biopsy or aspiration needed. Differential diagnosis of this patient is going to be a cyst, a fibroadenoma, are the 2 most common. Your least common are going to be your phloides, lipoma, and fat necrosis. On imaging, the cysts, we already talked about the cyst. What the cyst looks like on ultrasound, it's going to just be very simple. You can aspirate if the patient has symptoms or leave alone. If you aspirate and it comes back, then you need to do excision from the breast surgeon. This patient needs to be re-examined in 6 weeks for reoccurrence after excision. Patients with fibroadenomas, this is going to be the lump, maybe left in, a lump in the breast. It may be left in place or removed depending on the patient and the lump. If left in place, it needs to be watched over time, doing physical exams, mammograms, and ultrasounds. The lump may be surgically removed at the time with an open biopsy, excisional biopsy. We already talked about these. I don't have to go over this again just due to time. How will you approach the 35-year-old with the same type of mass? This patient, you're going to do a mammogram first. Mammogram is going to screen. You're going to do a diagnostic mammogram for this patient. The difference between your screening and diagnostic mammogram is going to be your views. So when you send people for a screening mammogram, they're going to get 2 views, which is a craniocaudal and a mediolateral. When you do a diagnostic view, they're going to get 4 views where they change the different angles on the mammogram and may do more. There is always a radiologist present for your screening mammograms, for your diagnostic mammograms, but not your screening mammograms. And you can use an ultrasound to differentiate between any mass seen like this on this mammogram, to differentiate between your solid and cystic masses. We already talked about the difference between benign and malignant findings on imaging. In the 55-year-old menopausal patient with a 2-centimeter mass, this patient you're going to do a diagnostic mammogram as well as a biopsy. So in summary, a woman's lifetime risk of breast cancer is 12% or 1 in 8. The goal of your breast cancer screening is to decrease the incidence of advanced disease. Benefits versus harms are going to vary by age for your screening. Don't forget that the probability of developing breast cancer in a 40-year-old is 1 in 69 and 1 in 42 in a 50-year-old. The relative risk of breast cancer and mortality from mammography screening is approximately 0.85 in a 40 to 50-year-old and in the 50 to 60-year-old. In the younger age group is an increased risk. It's important to remember that the younger age group is going to be an increased risk for false positive mammograms, leading to increased stress and anxiety of the workup of these imaging, as well as their additional procedures. The 3 most common breast complaints are in order: mass, nostalgia, and nipple discharge. Take-home points are going to be your screening. Y'all have a handout of this. We talked about the studies of how the U.S. task force kind of diverged from the rest of the other expert groups. Here's your complaints of a breast mass, breast pain, and nipple discharge. I didn't realize benign breast disease was going to be so massive. So, do you have any questions?
Can you comment again a little bit on the difference between diagnostic and screening mammograms, and how do you decide which one to order, what the difference in cost is, how the insurance companies decide whether they're going to pay for this or that one?
So the difference between your diagnostic and screening mammogram. So this is just real quick before I talk about that. It's very important for you to do a breast exam on patients that you're going to order imaging on, because that's how you're going to differentiate when you order the difference between those. So if you're suspecting a mass, if you feel a mass, you're going to do a diagnostic mammogram. You're going to do a diagnostic mammogram if the patient has breast implants, or if they have any kind of history of breast surgery that can make the screening mammogram be abnormal. And that's going to be, this is going to be it's on average of a 4 view. There's a radiologist that's present during diagnostic mammograms, versus on your screening mammograms, it's just your screening mammogram tech, and that's going to be just a 2 view craniocaudal and mediolateral mammogram. The cost is significantly higher for the diagnostic mammogram. I don't have the exact specifics, but that's the reason why we don't start straight off with that, is because there's multiple images. It's going to increase your risk of radiation exposure due to the increased imaging. And was there another question? Did I answer all of them?
Insurance companies, do you know how they decide whether they're going to pay for a diagnostic one?
I don't know the difference between the findings of the insurance companies. I would like to think if the physician had a reason, they would pay for it, but I don't know anything anymore.
Did you run into anything as far as when is the MRI indicated for screening and or diagnosis?
Yes, so you can use the MRI with a couple of patients. MRI is a great tool to look at breast disease, but it's very expensive. It's a lot more expensive than your screening mammogram and diagnostic mammogram. As well as you have to, if you're going to use your MRI to look at the breast tissue, it's more beneficial to place that does a lot of screening mammograms for your breast tissue. So it's radiologist dependent. You're going to use this more in your patients that have a history of like BRCA mutations, where you're screening for those, and every year those patients are going to get a mammogram and your MRI, and those are going to kind of, every 6 months they're going to get that. Also, patients, when the FDA came out with breast augmentations and implants, they recommended that patients get a baseline MRI, and then every 3 years get an MRI of their breast tissue to look for any kind of capsular complications or any masses that they can't see.
It's not. And I had one other question, a very thorough presentation that you've done. If your patient does present with a breast infection and it's not related to pregnancy or breastfeeding, do you first approach them with antibiotics or send them straight to general surgery for IND? Or?
So it's kind of dependent on the patient. As far as me, myself, and as well as the guidelines do say that you can give them a trial of antibiotics, 2 weeks, see how it does, and go from there. For me, I would look at the patient, the age. Is she really old? Is she really young? Is there an abscess there? What does the rest of the breast look like? How does the skin look? And kind of go from there.
Were there any antibiotic recommendations if you do treat?
You can use the dicloxacillin. It's just the same as mastitis you use for the same infections of breast. It's usually just from the abscesses are just from like sclerosed tissue and little mixed tissue.
Good job. All right. Thank you.
Done.